as representing the Association of Cardiothoracic Anaesthetists on NAP5. As JP has already told you, along with obstetrics, the headline figure is that we're overrepresented. I will leave you to judge whether that headline is justified after this talk. I'm going to start. These are my objectives. I'm going to talk about the rationale for the increased risk of AAGA in cardiothoracic surgery. I know many of you don't have the pleasure of working with cardiac surgeons, but I'm hoping that the case reviews we've chosen will be relevant to all of you. Cardiac surgery is overrepresented in all the big series of awareness under anaesthesia. Many of the studies that Michael Wang put up, cardiothoracic patients contributed a huge proportion of the cases. In the Be Aware study, nearly half the patients were patients undergoing cardiac surgery or cardiothoracic transplantation. Now, unlike Felicity and the obstetric anaesthetists, we don't do many rapid sequence inductions. I can't remember the last time I gave thiopentone, but we do use a lot of opioids. Why are our patients at increased risk? Well, it's many of the patients that have got minimal cardiac reserve, they're hypotensive, low cardiac output, and there's always that temptation to try and reduce the dose of anaesthetic drugs to avoid hypotension and cardiovascular instability. Having said all that, the incidence of awareness during cardiac surgery has been reduced from 10% with the very high opioid-based techniques used in the 70s down to nearer the order of 1% in most studies. Our thoracic patients are also at increased risk of AAGA. As we've heard before, they almost invariably have neuromuscular blockade. Many of the patients are frail and elderly. And one subgroup of patients, those having rigid bronchoscopy, are particularly at increased risk for the reasons shown. Now, there were 4 Class A reports of AAGA in cardiac cases. One of those cases was in the cath lab. That probably just reflects the increasing number of GAs undertaken in the cath lab, since many of you did your cardiothoracic training. There are many sick patients undergo anaesthesia there. Theatres, there were only 2 cases of AAGA during the primary cardiac surgical procedure, and one was during a return to theatre for bleeding. This is a case report which I hope will be of interest. This patient, it was an anxious young patient who needed an emergency CABG following a cath lab complication. Felicity's already highlighted the increased risk of awareness following failed regional anaesthesia. It seems if you're having a bad day, problems can only get worse. The anaesthetic technique chosen for this patient was a hybrid technique. It was a very low dose of propofol using TCI, medium dose fentanyl, and a dose of isoflurane. It would probably have got away with for most patients, but maybe not a young, anxious emergency. As you can see, the consequences for the patient were quite serious. This patient described a sensation of being alive only in her head and only her brain and ears still working. And the patient had severe post-operative complications. So that's one of the 2 cases that occurred during the primary surgical procedure. The second case I've chosen is also of interest. This is the take back for bleeding. It was a middle-aged patient who'd previously undergone a valve repair, and the patient was hemodynamically unstable, and because of that, the anaesthetist deliberately used BIS and intentional light anaesthesia. However, he maintained the BIS at 60, less than 60 throughout, and that was on the record. The patient, however, recalls waking up and hearing a discussion while he was being positioned, and at that time there was hypertension and tachycardia. Although the duration of the awareness was short-lived, the patient still had psychological sequelae. So that's an interesting case. It's awareness despite a BIS of less than 60. So cardiac cases, they contributed 1% of the cases, according to the activity survey, which is about 40,000 cases per year. This ties in pretty well with the our surgical colleagues are very tightly audited, and we know from the Surgeon's Blue Book that they do 35,000 pumps a year. Our cases also include the cath lab and takes backs for bleeding. But what is interesting to me is that there were only 2 cases of awareness during 35,000 primary cardiac surgical procedures. So although our overall incidence of awareness is quoted at 1 in 10,000, the actual incidence was actually lower if you look at the cases during the primary cardiac surgical procedure. What about thoracic cases? There were again 4 Class A reports. 2 of these cases were due to failure to turn on the vaporizer. One was in the anaesthetic room after insertion of the double lumen tube. The second was after transfer, we've heard about that from Jeremy, transfer to the anaesthetic room into the theatre. A third case was due to a tissued cannula, and I'll discuss that as a case example. And there was a 4th case where the anaesthetist fell down on 2 of J. Deep's Holy Trinity. He basically, the patient, the neuromuscular blockade was used, but there was no nerve stimulator. However, the patient was reversed. But there was a patient awareness of the tube, of a double lumen tube in recovery. The example I've shown, which I think is of relevance to all anaesthetists who do any sort of TIVA, is this case of a young patient undergoing a rigid bronchoscopy with the attended anaesthesia was target-controlled propofol with midazolam, fentanyl, sux, and mivacurium. Despite the intended anaesthesia, the patient was still able to blink and move as the rigid laryngoscope was put in her mouth. So fortunately, it was short-lived. Everyone recognised it was a problem. But the lesson for all of us is it was a tissue drip, and if you're giving TIVA without BIS, you need to keep an eye on the site of the drug infusion. So that's the take-home message. So thoracic cases contributed slightly fewer than cardiac, not surprisingly. The incidence was of the same order. What about depth of anaesthesia monitoring? It was used in actually more cases in the cardiothoracic population than average. Certainly nearly a third of cardiac cases had BIS, and there was one report where BIS was used, which we've already discussed. However, there were too few cardiothoracic cases of AAGA to draw any meaningful conclusions regarding the preventative effect of depth of anaesthesia monitoring in this setting. So these are our conclusions. The differences in methodology regarding BRICE have been discussed previously in several lectures. And I believe additional factors may explain the disparity in our findings. The first, I think, important thing is that cardiac patients at pre-admission clinic are invariably warned that they're going to be tracheally, they'll have an ET tube in their mouth and invasive monitoring when they waken in ICU. So I think many of the patients that perhaps complain of problems in recovery, if they're cardiac population, they're expecting it, and it isn't a problem. Similarly, the elderly cardiothoracic patients may be more tolerant and less liable to mention AAGA. Now, the average age of my population I look after is probably in the mid-70s. And it's notable that despite just doing 35,000 cases a year, there were no spontaneous reports of awareness in any patient over 50 during a cardiac surgical procedure, which I think was surprising to me anyway. And finally, the NAP5 incidence, it may reflect changes in anaesthetic practice. There's certainly been a lot more emphasis in the last decade or two about the importance of maintaining anaesthesia during periods of hemodynamic stability. And if you get hypotension, you should treat with fluids, vasopressors, and possibly early inotropes, rather than cutting back on the anaesthesia. And finally, we think that our population lends itself to research as to whether depth of anaesthesia can optimize the balance between light and deep anaesthesia. Thank you.